Okay, today really I'll show the techniques and the maneuvers, skills related to the general physical examination of a patient. Really in general physical examination you have first of all to introduce yourself to the patient and take a permission from him that you are going to examine him generally, and to provide him with full privacy via the curtain when a curtain is held and surrounding the patient. This is very important because this scene or this talks with the patient will provide a fertile ground for you to examine him, and I'll show you how to introduce yourself and how to take a permission from the patient. السلام عليكم. شلونك؟ ما أدري شلون صحتك اليوم؟ تسمح لنا نفحصك اليوم؟ فحص يديك رجليك وجهك إن شاء الله. Okay, على راحتك. Okay, really, I have taken a permission from the patient, and we have to provide him with full privacy. In reality, during clinical training and especially during time of examination, you have to introduce yourself. But because our volunteer, he knows me, I didn't introduce myself for him. And we have to put in our mind that the general examination, general physical examination, is conducted via two steps. First of all is the general look to the patient. Take a patient as a look, take a look at the patient as a whole, and put in your mind the following issues. First of all, the age group of the patient. How does the patient appear? This is one. Second one is the sex of the patient, awareness of the patient, whether the patient is aware, conscious, or he is lethargic, obtunded, and so on, from alteration of level of consciousness. Then the cubitus of the patient, I mean the position of the patient in the bed, and then status of comfortability, whether the patient looks comfortable or ill looking, and then body build of the patient, whether he is thin, long, or the patient is obese. And lastly, you have to check whether the patient is dyspneic, tachypneic or not. This is really the general look to the patient. This should be presented together with the next step of examination, which is the regional examination. In the regional examination, I'll check the patient region by region, and you have the right to choose either topographically examine the patient from the head down to the lower limb, or you can really take first of all the hands as a region for examination, and then ascending up into the axilla, taking the head, neck, chest, abdomen, and the lower limb, as I'll perform now. I'll start with the hand. I'll choose both hands. Really, I had to take a look at the posture of both hands when the patient was in supine position. Really, the examination of the hand is as simple as that. Take a look at the dorsal surface, at the palmar surface, and then ask him to perform the maneuvers for a tremor. As simple as that. So I'll take a look at the dorsal surface, looking for any thickening, any fissure, any ulceration, the posture, color, shape of the hand, and then take a look at the nail. Okay, abnormal posture of the hand may be neurologic in origin. When the patient, for example, had, just like I'll mimic the posture, if the patient had this posture, this is what we call it claw hand. If the patient, for example, had flexion posture, this is for hemiplegia or upper motor neuron lesion. This is second posture. Third posture, the patient may have wrist drop in radial palsy. Patient may have finger drop in posterior osseous nerve palsy, and patient may also have a carpal spasm, just like this, when the patient had a flexion at the metacarpophalangeal joint and extension at the interphalangeal joint with a position of the thumb characteristic of hypocalcemia. This is the abnormal posture. And then take a look at any congenital anomaly, for example, an extra finger here, we call it extradactyly or polydactyly, or there is fusion of both finger here we call it syndactyly. And if the patient had long, thin finger, we call it arachnodactyly, characteristic of Marfan syndrome. Then check the temperature. Check the temperature with your dorsal surface. This is a rule in medicine, back over back, because this side is always sweaty. And then check the nail for any nail biting, for example, that occur in eczema, in psoriasis, fungal infection. Check also the nail if they have colonychia, either flattening or concave in shape. Color of the nail, whether they are white, we call it leuconychia, or the half moon lanula that may be red, or this is really the lanula. This is the half moon shape. Proximal part is the lanula. It may be red in congestive heart failure, it may be blue in Wilson disease, hemochromatosis, and so on, from abnormality. And then check for the presence of clubbing. I'll ask the patient to perform this maneuver. بس خلينا أصابعك هيك. أيوة خليني يعني هيك. Okay, if we see here, there is a gap between the nails. This always should be present in normality. If it disappears, it indicates the presence of clubbing. The second maneuver that should be checked is to look across the radial side of the index finger. As we see here in the index finger, the middle phalanx had a depth more than the proximal phalanx and the across the nail. This depth is more than this depth. This is the normal. If a patient had a depth here more than this and the ratio is more than 1, this is suggestive of clubbing, and this ratio is called phalangeal depth ratio. Depth here, any clubbing will be more than the depth here. Okay, this is the first one. Second, let's take a look at the Loviband's modified sign. If we see here the distal part of the finger, this is the distal phalanx, there is an angle between the nail and the adjacent tissue. This between this nail and adjacent tissue, this angle is about 160 in normality. In patient with the clubbing, due to thickening of this part, it will be straight here and the angle will be 180. This is one. The second angle is the Kerr's modified angle between the middle phalanx and the distal phalanx. Here the angle is straight, that's to say 180 degrees. In patient with the clubbing, due to thickening of this part and proliferation of this part, the angle will reduce to less than 180. It will become of about 160. This is what we call it Kerr's modified angle, and here we call it Loviband's modified angle. This is about the examination of the clubbing. These two tests, Shamroth's test and inspection for the radial side of the finger, both these two tests are routine tests to check for clubbing because it is very important. After that, check the palmar surface of the hand for any thickening here, especially the early stages prior to fibrosis and involvement of the little and ring finger in case of Dupuytren contracture. Look also for the thickening all over in case of eczema, Naxos syndrome, and keratoderma pleonoragicum, and so on, and then hyperextend the palm of the patient to see the palmar creases as compared with your palmar creases. Because if, according to this maneuver, if the palmar creases are pale, the hemoglobin level will be less than 7. So it is as the same as me. And also look across the palmar creases. It may be black pigmented in case of Addison syndrome. Check also the other side. Don't forget to compare always with the contralateral side. And then after that, ask the patient to perform 2 maneuvers for tremor. First of all, I'll check for postural tremor, action tremor, and then for the asterixis or flapping tremor. حمارة تقدر تمد لنا يديك هيجي وبتفصل لنا أصابعك تقدر تستريح هنا. Okay, this is the maneuver. Just wait for a few seconds and to see if there is any oscillation just like this. This indicates tremor. If this happens, this indicates tremor. It may be fine just like this. This fine, or just like this. It is coarse. Then ask the patient to extend his wrist also for 20 to 30 seconds. You can, in Arabic, tell the patient that he should mimicking pushing something. يعني وكأنه تدفع فد حاجة هيك. After 20 seconds to 30 seconds, if no apparent tremor, you can enhance it by this maneuver. Okay, after that, if there is no tremor and we had checked the palmar surface, dorsal surface and the nails, I'll check the radial pulse. Really, you have to take an idea about the rate, about the volume and rhythm, whether regular or not, and to check the contralateral radial artery for radial inequality, and then the brachial artery slightly medial to the antecubital fossa using your thumb, and then check the contralateral one, and then check both brachial arteries for any inequality. After that, you have to check for the epitrochlear lymph node in the following manner. First of all, flex the forearm at the elbow joint to relax the joint here, and then slightly above the medial epicondyle here, and check the groove here. If any lymph node is enlarged, it will be palpable in this groove. Also check the contralateral one. Okay, after that, one should take a look at the lymph nodes in the axilla. Really, the lymph node in the axilla, this is the anterior groove. This is the posterior groove. Here is the lateral groove, and here deeply, very deeply, is the central groove. Really, the examination of the axilla just like this. I'll take the patient right arm, rest it on my right arm, and I'll examine with my left hand. Likewise, here I'll take the patient's left arm, resting over my left arm, and I'll check the lymph node by my right hand. After that, really, you have to check the external surface here, especially important because this is the site of insulin and heparin, and also here to check for any ecchymosis, for example, any lipodystrophy, lipohypertrophy, or lipohyperatrophy. In reality, during the clinical training and during the clinical examination, you may face or you may examine a woman. It's especially important here in our society because most our women are Muslims, so they are usually covered. Please, prior to uncovering this part of her hand, just be sure whether or not there is a cannula that is covered by clothes, because once you take off her clothes up, you may injure her, and it will be a very bad mistake for you during the time of examination.